Hello, I'm Donna R, founder and CEO of the Global Liver Institute, the world's largest liver patient advocacy organization. We're here today at Arizona Liver Health, one of our GLI Liver Action Network members, also a member of our NASH Council. We so often say that as we are supporting liver health, whether that is preventing liver disease or scaling solutions for people who are already impacted by liver disease, that solutions need to work in Seattle and Senegal. Today, we're seeing how they work here in Arizona. Thank you so much for joining us.
Hi, this is Dr. Naim Alkhouri. I'm the Chief Medical Officer and the Director of the Fatty Liver Program at Arizona Liver Health. Today we are welcoming a special guest, the Global Liver Institute team, to our Peoria office. Let me tell you a little bit about Arizona Liver Health. So we are a company that takes care of patients with all chronic liver diseases. We have 3 offices in Arizona, one in Peoria, one in Chandler, and one in Tucson. We also do clinical trials focused on chronic liver diseases, especially non-alcoholic fatty liver disease and non-alcoholic steatohepatitis or NASH. We've grown this company over the past 6 years, and now we have 120 employees. We typically have 20 to 25 clinical trials ongoing at each of our offices, and I couldn't be more proud of our team, and I'm excited to show the GLI team all the good work that's taking place in our offices. Thank you so much, Donna and the GLI team, for visiting us at Arizona Liver Health. This is our office in Peoria, which is a suburb of Phoenix. We're also opening a phase 1 unit to do advanced clinical trials in the Chandler area, and we hope to welcome you guys again in January of 2024.
So often we talk about the patient's journey, but today we'll actually see what that journey looks like inside a world-class clinic for fatty liver disease. So I have the privilege of being 28 years post-liver transplant. So I am very comfortable in an exam room. I know most patients aren't. And so one of the things I wanted to do today is just to explain what patients can expect when they come in for an exam if you suspect that they have fatty liver disease.
Thank you so much, Donna. And it's so good to see you doing so well after transplant, and this is such an inspiration for our patients. So when patients come with suspected fatty liver disease, usually they have elevated liver enzymes, or incidentally we see on an ultrasound or CAT scan that they have fatty liver disease. So they come to us, and initially we have them see our medical assistant. They do their vital signs, and then we actually obtain a FibroScan exam. This is a very easy exam. It's ultrasound based. There is no radiation, really no downside to it, and it's a simple machine, and I'll show you how we do the FibroScan.
This is very exciting to me because I have been in so many large imaging suites and had to go to different locations or down the hall in a corridor into the basement separately from a doctor's visit. So to have everything in one place is really a great advantage to patients, particularly as they're trying to fit in care, seeing their doctor into the context of their busy lives.
Absolutely. We try to do as much as possible in our clinics. So we do the vital signs, and then we do the FibroScan as part of the vital signs. In fact, I call FibroScan the hepatologist stethoscope. You cannot really practice hepatology and take care of patients with liver disease without having a FibroScan machine or a similar machine that can estimate liver fat and liver stiffness. And with the FibroScan machine, you get 2 numbers. One is called the CAP score, that tells you how much fat you have, so this confirms the diagnosis of fatty liver disease. The second one, it's called liver stiffness measurement, or LSM, and this tells you the stage of fibrosis, which is very important. Today, it's not acceptable to tell a patient, you have fatty liver disease, lose weight, you're going to be fine. We need to know if they have advanced disease, because these are the patients that may end up developing cirrhosis and complications such as liver cancer and decompensated liver disease. And we have a window of opportunity to intervene and actually reverse that, whether it's a lifestyle intervention or some of the new therapeutic agents, but also we offer clinical trials and provide access to cutting-edge medicines. So there's a window of opportunity, and we want to capitalize on it when we see the patients. So after we do the vital vital signs, we get the FibroScan results. Then I walk in. Typically, we collected the medical records. We know exactly what's going on before they came to see us. So we see if they had any labs done. We review them. I sit down with the patient. I ask them the usual questions. They tell me their story. We investigate about alcohol consumption, presence of metabolic syndrome, diabetes, and how they're being managed. And then I share with them the results of the FibroScan. And typically, we order additional blood tests. Just because someone has obesity or type 2 diabetes and they have elevated liver enzymes, we cannot assume it's only fatty liver disease. Fatty liver disease can coexist with other chronic liver diseases such as autoimmune hepatitis or hepatitis C. So we typically test for viral hepatitis, we test for autoimmune hepatitis, and then depending on age and the presentation, sometimes we test for other metabolic genetic liver diseases. So typically we do the blood draw here in the clinic. We have a phlebotomist, and then we send them out to a lab, and then we get the results within a week or so.
You held all that in your head. This is why it's important to come to a doctor who really knows and understands fatty liver disease. Because you said a lot of really important things that I want to underscore. One is that too often patients are told that they just have a little fatty liver disease and there's no further testing. And we both know that there are too many people who then end up with liver cancer or needing a transplant, and they could have done something in that window of opportunity that you talk about. For some people, that's 10 years that they could have done some type of care or diet or exercise or bariatric therapy or a dozen different things that we now know how to do in that window of opportunity. The other thing that you said I want to make sure that we underscore is that sometimes it's just a little liver enzyme slightly elevated. Sometimes there really aren't a lot of symptoms. So being able to take a look inside with the FibroScan or another type of non-invasive diagnostic is really important to understand if there is fatty liver disease and perhaps the severity of it and what type of blood tests or next steps need to be done. And so there's so many things that are packed into this visit that often aren't done to most patients. A question I wanted to ask is, how can a patient prepare for a visit like this? Knowing their family history maybe of diabetes or other types of disease or other lab tests that they have done. How can a patient, best help you in doing this work and having the best visit possible?
As you said, if they can be prepared and get us the medical records, sometimes, we request them, but unfortunately we don't have all the information. So if they have access to any imaging tests or blood tests, if they can bring with them. It's very important also to have an accurate picture about the medications they take and the dose. So I always tell my patients, either bring your medications with you or take pictures on your phone with clear, name of the medicine and the dose. So we know for sure that you're actually taking these medications, because unfortunately sometimes with the electronic medical records there is a lot that is lost in translation, and the patient stopped the medicine but it still shows up. So we need to know exactly what medications they're taking. So very important to be prepared, knowing your family history. So if you're not sure, maybe ask your parents, your siblings, hey, do we have anyone in the family who had fatty liver, cirrhosis, liver cancer? That would be very helpful. Before they come to the visit, we ask them to fast for 3 hours. So you don't have to fast overnight, but for the FibroScan test, you need to fast. And
explain what fasting means, because some people think, oh, well, I can still have my coffee with cream, or I can still have just a little bit of this. And so what do you want people to do when they fast for just the 3 hours?
Just water and maybe black coffee, but that's about it. So no breakfast, and definitely no cream, no milk, because when you eat, you increase the blood flow through the liver, and that can increase your liver stiffness. So it looks like you have more advanced disease. So we don't want to have that false positive result. But it's only 3 hours, so it's not a big deal. And we do FibroScan in the afternoon. So we say just skip your lunch and come here fasting 3 hours. That's very important. Most of the blood tests we do, you do not need to be fasting. So when we check liver enzymes, we check for viral hepatitis, autoimmune hepatitis, you don't have to be fasting. The only time we ask them to fast is if we're checking a lipid panel to check cholesterol and triglycerides. But most of the time, we are able to do the blood test without fasting. So I think these are the key things. Know your family history, make sure you bring your medications with you, and get us all the records you can get your hands on, and come fasting 3 hours.
I think that's easy for people to do.
And no alcohol. I mean, ideally, never, binge drink alcohol, but definitely not the night before you come see me.
It's you really can't, cheat the test for your liver exam, and I think that even making the appointment for meeting with a hepatologist, meeting with a liver doctor, should have you thinking about what liver healthy things that you should be doing anyways, which is cutting down or eliminating your drinking, lowering your amount of sugar.
Although I have some funny stories for you. So the other day I had this guy, he showed up with a t-shirt that said Monster Drinks, which is sugary drink, the last thing you want patients with fatty liver disease to do. And then he had a hat that said Guinness for beer. I'm like, you're coming to see the liver doctor. How can you have a sugary drink here and an alcoholic drink here?
He was posing you a challenge.
Yes. I've had patients also show up with bags of chips, and I say we shouldn't do this, and they're like, but they're so good, and then they bring me chips the next time. I'm like, no, thank you. So it is a society problem, obviously, and I have a lot of compassion for our patients with fatty liver disease. I always emphasize that this is not your fault. I don't want you to feel guilty. This is a society problem. It's bigger than all of us, but we can work as a team to resolve this problem. And I always tell them, you're going to have setbacks, you're going to have bad days. I don't want you to get frustrated. The key is to be persistent and continue the journey until we get you to where you need to be. Weight loss is also not just lifestyle intervention. We have a whole spectrum of things that we can do, from digital therapeutics, phone apps that increase engagement with the lifestyle intervention.
I know. I have at least two.
You're a good example. But we also have medications that we can utilize that really change how we think about managing obesity, especially the new injectable medications that work on what we call glucagon-like peptide 1 and some what we call dual agonists now. And then we have a whole field of we call endobariatrics, whether it's a stomach balloon or resurfacing of the duodenal mucosa, or even suturing the stomach from the inside to mimic the effects of a sleeve gastrectomy. And then bariatric surgery is also a good option for selected patients. So we need to be open to all these options and offer them to our patients.
I think that's really exciting to realize that there are things that we can do now. I think often patients, if they're told, or if they even hear about fatty liver disease or NASH, they're told that there's nothing that can be done. And you said exactly the opposite, that there are so many things that can be done now.
There's so much that can be done now, from actually seeing an expert who can help you with weight loss to certain medications that potentially may help a little bit, such as vitamin E and pioglitazone, utilizing the GLP-1 agonist as treatment for obesity and diabetes that can help the liver, optimizing the management of your type 2 diabetes. There are diabetes medicines that make fatty liver worse, such as insulin and sulfonylurea, and there are medications that can help, such as the new SGLT2 inhibitors and the GLP-1 agonists. So actually, seeing a specialist who knows how to manage fatty liver disease with what we have today is key. And the other important message is that we expect FDA approval of potentially the first NASH drug this year or next year, and this is going to be a game changer for everything we do, because number one, primary care physicians, endocrinologists are going to realize that this is not just a lifestyle intervention. There is more that needs to be done. They're going to realize that we're not going to use the medicine for every patient with fatty liver disease, so we need to exactly know the stage of their disease and only use the medicine when they have significant fibrosis. And then they also need to know that cirrhosis is something we need to rule out, and every patient with fatty liver disease is potentially at risk. So I think it's going to change their mindset that there is more than just, lose weight and do a lifestyle intervention. And then the medications are looking very promising. So we have 2 medications now in phase 3 trials showing efficacy on reversing liver fibrosis, so taking patients from, let's say, stage 3 fibrosis to stage 2, or stage 2 to stage 1, and this is within a year and a half of treatment, so very promising. We have one medication that showed efficacy on NASH resolution, so basically reducing liver inflammation and liver cell injuries. So I think these are going to be definitely game changers, and this is the first generation, and we will have second and hopefully third generation. So much is coming in the pipeline, and many of these medications are not going to just help the liver. They may help also lower your cholesterol. Some of them will help you lose weight, improve diabetes control. So I see fatty liver as the entry point for many patients, where they think they're doing okay, they're healthy, but they gained weight over time, and now they have fatty liver, and then we can actually tackle the liver disease, but help also manage metabolic syndrome, prevent type 2 diabetes, and prevent cardiovascular disease. And I see it as an opportunity for more medical professionals to be involved in taking care of patients with liver disease.
That's my hope as well. I'd love to go back on two things, because I think that most people don't realize that you can have cirrhosis without excessive drinking, that non-alcoholic fatty liver disease can cause cirrhosis. And just explain what cirrhosis is to people.
Yeah, so cirrhosis is when you develop so much scarring in the liver that your liver becomes nodular on the surface, and then the blood pressure inside the liver increases. We call it portal hypertension, and that leads to the complications of cirrhosis, including ascites, which is the accumulation of fluid in the abdomen. Some people turn jaundice, yellow. You can develop varices or varicose veins in the esophagus or stomach, and sometimes you develop something we call encephalopathy, hepatic encephalopathy, which is confusion from liver disease. So cirrhosis is really the outcome that we want to prevent. And unfortunately, many patients do not know that they have any chronic liver disease until they present with cirrhosis complications. So I did a study when I was at the Cleveland Clinic in Ohio, where we asked patients coming to see us for a liver transplant evaluation for NASH, fatty liver cirrhosis. And we asked them, did you know you had chronic liver disease before you had your first complication? And 68%, so 2/3, had no idea they had any liver disease until they presented with ascites, encephalopathy, or variceal bleeding. In my mind, this is not acceptable. And there are several studies showing that patients with cirrhosis that are admitted to the hospital, many of them, they've never been seen in a specialty clinic.
Wow. So that just really underscores the urgency of treating people for NASH, examining them, screening them for fatty liver disease and NASH as early as possible. The other thing that I think most people don't realize is the interconnectedness between fatty liver disease and diabetes and hypertension and high cholesterol. And each one can drive the other. And so there's an opportunity that you talked about in being able to really optimize all of those conditions and control all of those controllable factors, and really improve a person's whole health by coming in through this, liver, health opportunity. And I think that's something that people just think that these diseases are separate and siloed. But we have, come to understand that they're really interconnected.
You're absolutely right. We call fatty liver disease the liver manifestation of the metabolic syndrome. Metabolic syndrome includes obesity, dyslipidemia, hypertension, and type 2 diabetes. In fact, having fatty liver disease in patients without diabetes double your risk of developing diabetes. We did a study in San Antonio, Texas, where we looked at patients in their 50s, and we looked at a combination of metabolic syndrome risk factors and estimated the prevalence of fatty liver disease and NASH, the aggressive form of fatty liver disease. We found if you're actually from Hispanic ethnicity with type 2 diabetes and obesity, 92% will have fatty liver disease.
Wow.
So it's almost a given that you're going to have fatty liver disease. More alarming, that 45% had evidence of NASH, the aggressive and progressive form of fatty liver disease. So you're absolutely right. The more components of metabolic syndrome you have, the more likely you're going to develop fatty liver disease, and the more likelihood you're going to actually end up with more aggressive disease that can progress to cirrhosis. And we cannot be so liver-centric as liver specialists, so I'm always thinking about the entire metabolic syndrome and how can I help my patient optimize their blood pressure management, their diabetes management, how can they lose weight. I'm looking at their cholesterol and triglycerides. I also ask about snoring and fatigue, because obstructive sleep apnea is actually something that is strongly predictive of the development and progression of fatty liver disease. We also look at specific populations such as women with polycystic ovarian syndrome, PCOS. Sometimes they're not obese, but they have insulin resistance and they can develop fatty liver disease. About 35% will have fatty liver disease. So very important to actually think about it and screen for it.
So there are so many categories of people. I think this is why we start talking about liver health as a public health issue, because by the time you've gone through, listing all of the conditions that could possibly lead to increased risk for fatty liver disease, there should be many more people who are coming into this clinic. And the value that you just gave. If I'm a person who has been saying, maybe I don't have time for this doctor's visit, maybe I'm pushing it off. Maybe there are other things that should be more important. What I just heard was the value that of all of this information, of all of this, testing to so many aspects of my health, to so many things that I think people are dealing with. Well, I'm just a little tired, or I just have a little of this and a little of that. But I think coming in, making the time to come in for this visit, for this type of conversation, I really think could benefit so many people and really put them on the path to really much better health.
We truly believe that anyone with type 2 diabetes need to come and get a FibroScan done to check on their liver health. And we also want anyone with dyslipidemia, obesity to consider also coming. If you've ever been told you have elevated liver enzymes without a clear explanation, I think doing a FibroScan is a good idea. We actually believe in this, that we offer free FibroScan for anyone in the state of Arizona. You can just walk in. We will not charge your insurance. We will do the FibroScan for free. So I really want to take this opportunity to invite anyone in Arizona to come and check on their liver. My dream is that, the same way when you see your diabetes specialist, they tell you need to do an eye exam, they check on the kidneys, they do a foot exam. They need to send you to get a scan of the liver. And we have the FibroScan machine in our clinic, but also, as I mentioned earlier, there are other technologies out there. So I think it's becoming more and more available to anyone who's interested.
That's an incredible opportunity for everyone in Arizona. There's no excuse, no barrier to be able to get this screening and understand the status of your liver health.
Free FibroScan.
Dr. Alkhouri, one of the additional opportunities that patients with fatty liver disease and NASH have is to participate in clinical trials. What does that conversation look like with patients?
Yeah, thank you so much, Donna, for asking me this important question. So clinical trials are really a good opportunity for our patients with NASH and significant fibrosis, because today we do not still have an FDA-approved medication. And as I mentioned, there's a window of opportunity where you can act and reverse the disease. So typically we have several therapeutic agents that can target almost every step in disease development and progression. So we can target obesity, insulin resistance, we can target lipid loading into the liver. We can actually block the enzymes that make fat go inside the liver cells. We have medications that can also block the fibrosis pathway and decrease the scarring of the liver. So it's really a good opportunity. In the clinical trials, usually I tell the patients that, this is completely up to you. This is an opportunity. I promise you that everything we do will be explained to you in full transparency. I tell them that, in the clinical trials, you have the opportunity to be on medications that are not available for us to prescribe for you today. The clinical trials will be done absolutely at no charge for our patients. I tell them that you can stop participation in a clinical trial at any point. I tell them we want you to go into it in good faith and assume that you're going to complete the whole trial. And I think patient retention is very important for any clinical trial program. But I tell them that if anything happens, and in life you can never predict the future, so if things happen, that you can stop the trial at any point. I explain to them that in the vast majority of trials we have, there is a placebo arm, so you may not be on the active medication, but typically most patients will be on the active medication. So typically we have like 3 arms in the study, and only one of them will be placebo. So I tell my patients that the chances of you being on placebo are only 15 to 30% typically, which leaves you 70 to 85% on the active medications.
But even the placebo means you're still getting the best standard of care that's available, that you know how to do. And so participating in a clinical trial, isn't just an experiment or something that people should be afraid of. At the minimum, you're getting like the best standard of care, and then you might have the opportunity to be on some cutting edge medication, really at the forefront of medicine. I think a lot of people, particularly people of color who think about clinical trials, I don't want to be part of an experiment, I don't want to be a guinea pig, but I really think about it as I want to be part of the future of medicine. I want to be first in line for access and attempt at the best medications, the best possible medications, and make that possible for other patients. And to your point about staying through a trial all the way through, even though it may be weeks or months, or some trials are even years. It's really important, that contribution to science. I know the patients who have participated in trials really feel that sense of satisfaction and part of this entire enterprise of science that they've really helped enable. But you can't do it without patients participating in clinical trials.
Yeah, I couldn't agree more. And as you said, they really get the best standard of care out there, absolutely done for free. And I always tell my patients, you're not only trying to help yourself and your illness, but you're also helping medicine and science, and potentially millions of people and future generations. And you could be helping your own family members. We know that there's a genetic component to NASH and fatty liver disease, and if you're part of the drug discovery process and we get these medications to become commercially available, it can help your own family members and future generations. And I'm glad you brought up the idea of, I don't want to be a guinea pig. And I think, it's important for the principal investigator or, the person approaching the patient about the trials to understand the mechanism of action of the medicine, what phase in the clinical trial we're in, because different patients have different tolerance for, potential for adverse events. So when we have a phase 3 trial, typically it means that this drug has been tested in healthy volunteers and hundreds of patients with the disease, especially when you're talking about NAFLD. We have good safety data. We have some promising efficacy data, but of course, to get the medicine to be FDA approved, we need the large studies that include typically 2,000 patients or more to get to that FDA approval. But participating in a phase 3 trial is definitely less experimental than a phase 1 trial. So, for our patients, ask about how far along is the drug in the development process. And, we have patients that are interested in participating in phase 1 and phase 2. So I think that's also very, very helpful, but it's important for the patients to understand, the process.
Right. And the process is one that we teach in the Global Liver Institute's Advanced Advocacy Academy that you have been so helpful to speak at, and demystify that process, that there are 4 phases, and just really understanding both the clinical side and the legal, the regulatory side, that now patients have an opportunity to participate in as well. And I think that's one of the differences in today's clinical trial environment. And one of the things that I hope would make people feel more comfortable in participating, to know that there are patients who have had input into how the clinical trials are designed, how the protocols are even communicated. There are patients who are sitting on clinical trial advisory boards and institutional review boards. And so it's not just the patients who are in the trials who are engaged, or all of us are, as patients, are now more engaged in every facet of the trial, through even sitting on, as I've had the privilege of doing, on FDA advisory committees to see whether the clinical trial data pans out and a drug should or should not be approved. And so hopefully people knowing that that other people like themselves are involved in all of those stages alongside wonderful physician researchers like yourself would also give them more confidence in clinical research.
Yeah, I absolutely agree. And I think, the patients that we include in clinical trials, once they finish a trial, they usually want to go on the next one. And they're very excited to learn about what happened to their liver and did we achieve any improvement. And I'm always impressed with our patients. I feel you're part of drug development. You're taking something from a concept and initially, just some very investigational studies all the way to being on the market and being able to prescribe the medicine to our patients. I think it makes me a better clinician also being involved in clinical trials, because I feel like these medicines that are about to be approved, I've been using in our clinical trials for the past few years. So I'm very familiar with the adverse events, with the efficacy endpoints, with what to expect when you get on this drug. So it will help me educate other physicians also how to prescribe the medicine and what type of discussion they need to have with their patients.
Now, what's an adverse event? That sounds like a very big thing, but sometimes it can be something really small, like just itching.
Yes.
So, or it could be something, very serious. So what's an adverse event?
So adverse event is basically any side effect that you experience during a clinical trial. And believe it or not, even patients in the placebo arm, they have plenty of adverse events, because if you are in a clinical trial and you have a headache, even if it's related to stress at work, you have to tell us, and then we have to report it as an adverse event, because we really don't know if it's related to the study drug or it's just a headache that was going to happen anyway. So that's why, having that placebo arm is very important, not only to show the superiority of the medicine in terms of efficacy, but also to understand the adverse events and see if there is a signal that, the drug is causing, something more frequently than placebo. So if you're in a clinical trial and 20% of patients on the drug have headaches, but then 20% also in the placebo arm have headache, then probably it's not related to the study drug. So we're very careful, and we tell our patients, no matter anything happens, you need to let us know and we will report it. In fact, even if you end up going to the emergency department, or if you get admitted to the hospital, let's say related to COVID-19 or pneumonia, we have to record this. We have what we call serious adverse events. So these are, potentially sometimes, related to admission to the hospital, anything that's considered life-threatening. But luckily in the NASH trials, this is a very rare thing that we deal with. And you have to report everything in full transparency. And we take pride in being very meticulous and thorough and, documenting everything and then communicating also with our sponsors so they understand. And the sponsors do a great job also in communicating with all the sites whenever there's a potential for any serious adverse events. So we take it very seriously.
I think that's just part of the confidence that people can have in clinical trials, that all of these things, whether they're minor or major, are accounted for. One of the things that people ask is, okay, I want to participate in a clinical trial. Like, what does that mean? How often do I come in, and what happens do I come in? For some, my understanding is it could be some of the visits are just surveys or questions, and then some may be full full exams with blood work and things like that. And so if someone is participating in a trial that, over the course of a year, for example, how many times would they see you or some of your clinical research staff?
I love all your questions, Donna. Thank you so much. I mean, you bring up so many important points. And, it is more frequent clinic visits, but this is very important for safety and to assess also for outcomes. So what I tell my patients that, if you agree, we're going to give you a consent and explain to you what's involved in the study and make sure that you're comfortable. And then typically we do what we call a screening visit, which is a longer visit. It'll take a couple of hours, but we have questionnaires. We take blood work. Typically we do an EKG and we review your entire medical records, review your medications, make sure you qualify for the trial. And then, depending on the trial design, but sometimes you need to have an MRI of the liver to quantify liver fat and look at liver fibrosis or inflammation. And then most studies require a liver biopsy at baseline. Not all, but the majority of studies today. And I hope this will change in the near future. And we are working very hard on changing the endpoints with the FDA. And we need your help with that because I think a liver biopsy is not the ideal way to assess for disease severity and progression.
I've had 6 liver biopsies, and so I really...
And when it's all said and done, it's really not a big deal, but, if we can avoid anything invasive, that would be ideal.
It does have some risks, and it does take much more time than the non-invasive diagnostics take. If we can do it at less risk to the patient, I think we should really move forward to do that.
Definitely, yes. So after we do the screening visit, the MRI, the biopsy, if they meet the criteria, which is typically that they need to have advanced disease, so they need to have NASH and significant fibrosis. So this is important for patients to know that, if the biopsy doesn't show us that you have significant disease, you're not going to qualify for the trial, and we're going to tell you need to focus on lifestyle intervention. So you only get in the trial if you really need to be on the medicines. So this is an important point.
And why is that? Is so, for this point in this sort of scientific, validation of a medication, you want to be able to show a size effect. And if someone has more advanced disease, there's a better opportunity to show, the effect of the drug versus somebody who maybe only had a milder stage of the disease. Is that why you're looking for patients with more advanced disease for clinical trials, or is there something else? Because I don't want people to be excited about clinical trials and then disappointed that they can't get in one. But there's a scientific reason of why you're selecting particular patients for particular trials.
No, usually we do a very rigorous assessment of disease severity before the biopsy. So we do our blood test, we do the FibroScan, we do the MRI. So the idea is that we want to find the real disease when we do the biopsy. But it's twofold. So number one is to show that size effect and make sure that you can show actually improvement, because if you start too early, you don't have enough room to show improvement. But also because we don't want to use medications if we can actually get away with just a lifestyle intervention. I just want to treat the sick patients that are on their way to cirrhosis. As you know, fatty liver disease is a slowly progressive disease, and with lifestyle intervention, you can reverse it in early stages. So, we're not here to promote medications. We're not here to, medicalize a condition that can be treated with the lifestyle intervention. But we also realize that, if we don't intervene when someone is showing you all the signs that they're on their way to cirrhosis, that you may lose that opportunity, and then you end up regretting not actually giving the medicine. So we want to find that sweet spot where the medicine is indicated, it can make a difference for the patient, because with any medicine, you're going to have also potential for side effects. There's cost associated with it, and we have to be mindful of the cost to society. Sometimes, we hear that, oh, don't worry, your patient is not going to pay for this medicine because we have a program to support them. But I'm like, but someone is paying, so we have to be mindful of this, and also, pressure the pharmaceutical companies to give us reasonable prices for a disease that affects 30% of adults in the United States, and many of these patients will need to stay on medication potentially for decades. So we need to have something that is affordable, that's cost effective, that's indicated only for patients that have significant disease, to minimize costs and adverse events and potential for unwanted side effects.
I think that brings so much credibility and even more confidence to the system to know that there's a solution for patients at every stage, but structured lifestyle and perhaps more support, more dietitians, more like the team-based approach you have here at Arizona Liver Health can really help a large majority of patients. And then for those who are sick enough to need a medication, we are working to develop the medications that work on the specific mechanisms, and you named different ones that the different clinical trials are researching, whether it's inflammation, fibrosis, or liquid reduction, that people may need. And so I think searching for just that right solution for each patient should give everybody a lot of confidence in clinical research.
I always agree with whatever you say, Donna, because you say it eloquently, and honestly, it makes perfect sense for our patients. We appreciate you guys raising awareness about all chronic liver diseases. I know you have a special interest in non-alcoholic fatty liver disease, but the work that your organization is doing in autoimmune liver disease, pediatric liver disease, raising awareness about all the good work that's being done in the clinical trial space, we couldn't be more thankful to you guys. And that's why whenever you tell me you want to do anything with Arizona Liver Health, we are available to you guys, because again, it's a two-way street, and it takes a village, and you're a big part of the hepatology community now, and we always appreciate having you around.
Thank you. Thank you so very much.